Good morning, my name is Dana Gavino and my topic is gene panel sequencing and the prediction of breast cancer risk. First, we have the definition. This multi-gene testing or panel testing is a practical option when looking for genetic variants that may be associated with a risk of breast cancer. Genetic tests should be evaluated on the basis of the four criteria ACCE: analytical validity, clinical utility, and ethical, legal, and social issues. Now we have a description of these criteria. Analytical validity refers to the degree of accuracy with which a test detects the presence or absence of a mutation. The key question of clinical validity are the variants the test is intended to identify associated with disease risk, and are these risks well quantified? The validity of the risk estimate is a key determinant of the clinical utility of panel testing, which in turn should inform decisions regarding the adoption of the testing in clinical practice. It follows that the identification of a variant conferring a relative risk higher than 4 in the absence of any other data can place a woman in the high risk category. In contrast, a variant conferring a relative risk of 2 to 4 will place a woman in the high-risk category only if her risk is increased by other factors. Now we have a video.
Cancer is the result of mutation of the genes responsible for the growth and health of the cells in the body. This abnormal proliferation may occur to the breast cells, which is called breast cancer. Breast cancer cells may continue dividing without a halt, resulting in a tumor. Breast cancer is common to women, but men are also susceptible to breast cancer. People suffering from breast cancer may not show symptoms at all, especially in its early stages. But a new lump or mass in the breast can be indicative of breast cancer. Generally, any change to the breast appearance, texture, and pain can be a sign of breast cancer. Nipple discharge or redness, breast or nipple pain, dimpling, or swelling of the breast can also be signs of breast cancer. Breast cancer has better prognosis once treated in its early stages. Thus, women are advised to undergo routine screening procedures to detect breast cancer earlier. Monthly breast self-examination, clinical breast examination, and mammography are the recommended routine screening procedures to detect breast cancer, even without obvious symptoms. Breast cancer development can be associated with a family history of breast cancer, early onset of menstruation, late menopause, dense breast tissue, exposure to carcinogens, the use of oral contraceptives, or drinking excessive alcohol. Breast cancer has various types. Some types are ductal carcinoma, lobular carcinoma, mucinous carcinoma, mixed tumors, and inflammatory breast cancer. Treatment of breast cancer is dependent on the type of cancer and its stage. Basic treatment options available to breast cancer patients are surgery, which involves the removal of the cancerous tissues, radiation therapy, that aims to destroy cancer cells by the use of high-energy rays, and chemotherapy, which treats breast cancer with medications. Consult your general practitioner whenever you notice any changes in your breast. He or she can examine you and refer you to a specialist if necessary.
Now we have the pros. The panel testing helps to have an idea of the risk a woman can have cancer in the future. Cons. Although it would be ideal to have specific evidence for every variant detected, most variants for which there is a suspicion of an association with a high risk of disease are rare, and the sample size required to establish a allele-specific association with risk are so large as to make the task infeasible. A potential problem with this method is that it does not indicate whether any specific variant identified is associated with disease. It is often assumed that all protein truncating variants are equally pathogenic. However, all such variants don't confer the same risk. For missense variants, the situation is even more problematic. Another video.
BRCA officially stands for breast cancer early onset. There is a BRCA1 and a BRCA2 gene. We find that when a person has an abnormality or a genetic mutation in BRCA1, depending on the type of mutation, these could evolve or predispose an individual to a higher risk for breast or ovarian cancer if you're a woman. BRCA2 has a mutation spectrum in not just breast and the ovary, but a variety of different cancers like colon and pancreatic. So essentially these genes, although they're similar in sequence, the spectrum of cancers that eventually evolve from these mutations are slightly different. We found that there are some mutations that occur in BRCA1 that may not necessarily predispose a person. So it's a very, very large gene, and there's an opportunity of mutations across the entire DNA sequence, and it's not entirely clear which particular mutations lead to the predisposition for cancer. Typically, those who are at a higher risk for development of breast cancer are those who have someone in their family, their mom or their dad's side, that have already been diagnosed with a particular cancer. If they do find a family history, make sure they align themselves with a genetic counselor who can explain to them what a positive or negative test would mean should they choose to be tested for BRCA1.
We continue. Application in medicine. The clinical validity and utility of testing for variants in BRCA1 and BRCA2 are well established. There is overwhelming evidence that most protein-truncating variants in these genes are associated with a high risk of breast cancer and other cancers. Mutation in TP53, CDH1, PTEN, STK11, and NF1 cause pleiotropic tumor syndromes in which breast cancer is only one feature. Germline's mutation in TP53, both protein-truncating and missense mutation, are responsible for the Li-Fraumeni syndrome, in which carriers are predisposed to childhood sarcomas, brain tumor, adrenocortical carcinoma, and other rare cancers in addition to breast cancer. Mutations in PTEN are associated with the Cowden syndrome, in which breast cancer is a characteristic of the clinical phenotype 16-17-42, and mutations in STK11 are associated with the Peutz-Jeghers syndrome and increased risk of breast cancer. Protein-truncating variants in CDH1, which are known to be associated with diffuse-type gastric cancer, are also thought to be associated with an increased risk of breast cancer. Recent cohort studies 20 and 21 have reported an elevated risk of breast cancer in women with neurofibromatosis type 1. There is strong evidence that protein-truncated variants in 4 other genes involved in DNA repair confer an increased risk of breast cancers. Among these genes, mutations in PALB2 appear to confer the highest risk. Another video.
Angelina Jolie had a family history. Obviously, her mother had been impacted by ovarian cancer, and she passed from that disease. And based on that high risk of having a family history, she sought out to stratify her risk. Where did she fall in regards to risk for developing breast, ovarian, and related cancers? When we start that discussion with our patients, we oftentimes try to pull in that affected individual. So if we're having a risk counseling session and we do opt to test the family, we prefer to test the affected individual. There's a percentage of women who, when you go through all of their options, so there's screening, there's preventive medications, and then there's obviously preventive surgery, it really takes an internal cost benefit ratio that they have to really talk through. So it requires us to provide them with information that's accurate. We don't ever make a decision for them. We just help them process that information. And about 30% of women like Angelina would go ahead and have both of their breasts removed. How do you handle stressful information or risk in your life in general? And for a lot of women, knowing you have this elevated risk, knowing that every day you're going to be thinking about it, that's a lot of weight for a lot of women to handle. So knowing you can take that risk from greater than 50%, and for some women, obviously that goes up into the high 80s, you can reduce that risk down to less than 10%. And if you're going to a dedicated breast surgeon, that risk is probably closer to 5%. So when you compare that to general statistics, you're much lower than the general population by removing that breast tissue. Most of the patients we see fit into a high-risk category, and that's about a 15 to 50% lifetime risk of developing breast cancer. Only a small subset of patients would actually fit into a hereditary risk, like Angelina, and that means that they've tested positive to a genetic test. In particular, the ones that were looked at for her were called BRCA1 and BRCA2, but there's other genes out there that we look for as well. And most of the patients we see, obviously in a high-risk clinic, don't fall into a general or sporadic risk. But let's say that in a family like Angelina's, her mother had tested positive. We tested her and she was negative. She would actually get to go down into a lower risk category. So the only way we can really take a high-risk woman and reduce her risk is by understanding what that genetic test would tell us. Things have changed a lot. We used to primarily do blood testing, but now we do things called buccal samples, and that basically we like to use sort of easy things to understand, which is you sort of swoosh and spit. So it's collecting cheek cells by taking a mouthwash and swooshing it around in the mouth, and then you collect it into a tube. That tube is then sent to a testing company, and the DNA is actually extracted from the cheek cells. They're the same DNA. Our DNA is the same no matter where we really collect that from. So this has been a much easier way, so that especially if we have women who are unaffected, we don't have to send them for a blood draw anymore. They can simply have a spit test done. The gene testing looks for two genes called BRCA1 and BRCA2, and these are called tumor suppressor genes. And the way I like to explain them to a patient is it's sort of like you have a highway patrolman who's supposed to cruise down the highway and identify those speeders. But if he's stuck on the side of the road, the speeders are going to keep going by. So tumor suppressors are supposed to stop abnormal cells or cancer cells from growing. And if the mechanism in our body isn't working the way it's supposed to, then those cells will continue to grow uncontrolled. So the important piece is not just to look at the family history, but we want to look at the individual. Because for a lot of patients where there is a negative test, they still have risk. And if you think about some of the other risk factors, the biopsy, having babies later in life or not having babies, lots of hormonal factors. When did you start your period? When did you go through menopause? All those factors are very independent to the individual. So regardless of what else we see in the family history, there's a lot of things that can be individual to the person as well.
We continue. Issue in Ecuador. The University of America hosted a genetics symposium in 2014 with the participation of 22 national and 2 international exhibitors. Advance in genetics research in the country was displayed. The most prominent studies have focused on the analysis of stem cells. At the Institute of Biomedical Research in Quito, cancer cells are grown and introduced a previously designed and manipulated genetic sequence. From the observation of this behavior, you could get a process to block reproduction of cancer. Another video.
Hello, this is Debu Tripathi, Editor-in-Chief of Cure Magazine, coming to you from the 32nd Annual Miami Breast Cancer Conference. One of the topics that was covered today that really affects a large number of people is that of genetic testing for familial risk for breast and ovarian cancer. Over the last 10 to 15 years, we've identified specific genes that people can inherit if mutated will increase the risk of breast and ovarian cancer by many fold times. And it's important for us to detect this. Many times patients are diagnosed at the time that they actually develop cancer, and we find out from their family history that they may carry one of these genes. The two most common genes are BRCA1 and 2, and it's estimated that in the general population, maybe 1 in